panelists right now.
There are two accounts called Abi Shan raising the hand, and many other accounts with the name of Abi Shan. I can see them.
Yes, I believe that Ablation gave her account for everybody to join using it.
Now here is only one account that Ablation has raised his hand. Only one now.
Yes.
陈明我可以了，
OK。
是个 Ablation， 我要改个名字嘛，来不及了。你跟他们说一下好了。
Dr. Jiang is our professor now. He used the account named Ablation, but it doesn't matter. He will give our address.
Very good. Did he join already?
Yes.
Okay,
yes,
perfect.
already.
Yes.
It's a pleasure to meet you, Professor Jiang.
Good morning, Professor Jiang. It's Dr. Mohammed Abdelbari and Dr. Omar Khashaba from Istir, and we are happy to collaborate with your school, your institute, and we are happy to have you as our distinguished speaker today with Dr. Chen and Professor Wang. And we will be starting maybe in a 5 minutes time.
OK.
可以了吗？现在我听得到我声音吗？
听得到。他们
我可以说了。
开始。
我先讲两句啊。
他说5分钟开始讲的。
过5分钟是吧？
过5分钟开始。
好。我的名字是怎么改一改？
名字我是登录进来的时候修改的。
那算了，就不要改了啊。前面我进来过了。我估计这名字不对。我如果不对着摄像头，我这个到另外一个界面，你还看得到我吗？
我不确定，我自己只能看到我自己的账号。现在没有了吗？
没有了啊，好的。
If you excuse me, Professor Dr. Chen, is Professor Jiang, is he going to share from his own computer? Will he share a document? Will he share a document from his computer?
From my own computer. Dr. Jiang uses his iPhone.
Okay, perfect. So he's not going to share a document so we can test that he can share his own document. We don't need to do that, right?
Yes.
Perfect.
Dr. Chen, excuse me, you know well that we are not very clever in pronunciation of the J. When you pronounce the J in Chinese, it's a bit difficult for us because maybe it's pronounced as S or something. You understand me?
Yes, I understand. I will speak English and I will translate.
So yes, please just make Professor Jiang and Professor Wang notified that we are trying hard to get the proper pronunciation of their names. Maybe the J is not that easy for us. Do you understand me? So we are sorry if we didn't pronounce the names very well. Okay, can you just let them know?
Don't worry, that's fine.
Okay.
Shall we start?
If you prefer to start right now, you can do that. However, the numbers are increasing by the minute. So if you can wait for about 5 more minutes, but it's as long as what you prefer. No worries.
Wait 5 minutes. Okay.
Okay. Now the attendees are almost about 35, and they are increasing by the minute because we should start at 1:15. So we still have 2 minutes to start. Has either of you been to Egypt before? We're trying to make use of the time until we start. Have you been to Egypt before? Can you hear me, Dr. Chen?
Pardon?
Have you been to Egypt before? Did you visit Egypt before? Either of you? Egypt. Our country. The pyramids.
I have not been traveled to Egypt before.
Okay, interesting. And the same goes for Professor Jiang?
I think
No.
No, you haven't. Well, we would definitely love to have you here. Now with the new museum, I believe you are aware of the grand new museum in Egypt, in Cairo.
I have watched a movie that introduced
陈雷，我们以后有机会我们一起去啊。
a movie that introduced the museum of Egypt.
Yes, the new museum right now, it's supposed to be one of the largest museums concentrated on one civilization at least. And it's right next to the pyramids. You can actually see the pyramids from inside the new museum.
Wonderful. It's wonderful.
Yeah,
I know, have Dr. Omar, I would like to thank you so much for this outstanding design that reflects the civilization of the Chinese history, because you know that Egypt has a very long and old civilization. Also, China. I know well that they have very historic and old civilization, maybe of 200 and 300 years, something like this.
Yes, China is one of the oldest civilizations and one of the greatest ever, that's for sure.
Yes.
And there was a long trading history between Egypt and China as far as the Silk Road, if I understand correctly. So yeah, there has been a long of collaboration between the two countries.
So maybe we can start right now because it is 1:16.
I believe so. If you would like to start, let's go ahead.
Okay.
Okay. Good day, everyone. And welcome to our second Steer School webinar. Over the next 1 hour, we are going to explore the state-of-the-art interventional treatments of varicose veins. And before we begin, we would like to welcome our esteemed professors, our distinguished professors from China. Professor Jinsong Jiang is a discipline leader of vascular surgery and the vice president of Zhejiang Provincial People's Hospital. Also, we have Professor Jinsong Wang. She's going to be a bit late since she has some still commitments in her work list, and she will join later. We have Dr. Li Chen, the consultant of vascular surgery in the same institution, the Zhejiang Provincial People's Hospital, and we are happy to be collaborating with the institutions, the Zhejiang Provincial People's Hospital and Guangdong Provincial People's Hospital as well. And we would like to appreciate the efforts of Curaway and Synergy in preparing this scientific meeting and the program. So thank you, Abby and Bassam. Now let me start with a short introduction about our society, STEER. I want to be sure that you are seeing the screen right now. Are you seeing my screen?
Yes, we can see it.
So, founded and registered in 2024, STEER started with 15 founding members, and currently we are proud to have more than 150 members joining, either learning or practicing interventional radiology. Those are the founding members originally started the work, and we have maybe 4 more founding members in our team. The name STEER is not just a word. Actually, it reflects our mission and vision. E is to enhance collaboration with other clinical specialties. S, to support the development of the IR practice in medical institutions. T, to train and educate interventional radiologists. I, to inform the general public about how IR can impact their treatment journey. And R, to enhance research and publication. Over the last year, we achieved collaboration with CERC, and also we exchanged experience and efforts with the SAPHIRE, the Society of the African Interventional Radiology and Endovascular Therapy. Also, we established training partnerships with Siemens and the IR Pathway. Our inauguration event featured Prostate Interventional Day. And then we arranged a hands-on simulator workshop in collaboration with Siemens, a cath lab simulator workshop focused on ischemic stroke, uterine artery embolization, and hemorrhagic stroke. And we also arranged several hands-on thyroid intervention workshops across multiple institutions. We hosted the first STEER school webinar. It was about mechanical thrombectomy, and we had Professor Wim van Zwam, who is one of the most famous and one of the mentors of the interventional stroke therapies. We contributed lectures and workshops in numerous conferences, and particularly we are going to participate in the upcoming Egyptian International Radiology Conference taking place in a couple of days at the end of this month. And finally, it's my pleasure to invite all of you to join our major upcoming milestone, the ISTEER First Annual Scientific Conference, taking place on May 10th, 2026. And at the end, I would like to welcome everyone, and we are going to start our webinar with opening remarks provided by Professor Jiang. So let's start, and please leave your questions in the question and answers box, and feel free to ask. We'll have a 15 minutes discussion by the end of the webinar. Thank you so much. Professor Jiang,
好，
can we start the opening remarks, please?
Yeah, 好 ，Thank you。感谢埃及同道对我的邀请啊，我呢，因为请那个陈磊博士做一个翻译。
Thank you for the invitation, and I will translate it for Dr. Zhang.
现在在中国是晚上了啊，在这个时间，非常荣幸的能够参加由这个埃及这个放射学会啊，这个放射介入学会主办的这个静脉曲张的微创治疗的这么一个研讨会。
Now here is the night, and I'm very honored to be invited to join this meeting. And this webinar gives me a chance to translate with all of the colleagues from the world.
浙江省人民医院是我们中国这个下肢静脉曲张微创治疗啊数量最多，也是开展最早的这个医院之一。
The minimal invasive treatment of the varicose vein. Here, our hospital is performed very good, and is the first hospital to perform many different methods to treat the varicose vein.
基于中国这个巨大的人口，我们2025年预计我们的下肢静脉曲张的这个射频消融的手术量会超过4000多台。
According to the large amount of the population, the total minimal invasive, especially radiofrequency surgery in our hospital to treat varicose vein, the amount may more than 4,000 operations. 2026.
所以呢，因为中国的这个地域非常的广泛，所以说我们中国在下肢静脉曲张的这个治疗的微创理念上也存在着很多的一些差异啊。
Due to the large the scale of our country, from the east to the west, different locations have many different methods to treat this disease. So I will present my opinions.
所以作为中国的这个血管外科学会的静脉曲张学组的组长，始终也承担着这个普及这个静脉曲张微创治疗的这个理念的这么一个工作啊。那么今天呢，很高兴 今天呢，很高兴跟埃及的同道可以在线上一起探讨这个下肢静脉曲张微创治疗的一些理念啊。期待呢，我们有更多的机会，邀请更多的埃及的专家能够来到中国，或者我们中国的专家能够来到埃及啊，能够一起这个面对面的探讨。那么这样的话呢，可以有助于我们共同的这么一个进步。
I'm the chairman of the Varicose Forum of China, so it's my duty to change the opinion about the treatment about varicose veins, and I am also very glad to be invited to Egypt, and also I want to invite Egypt colleagues to China to exchange our opinions about their disease treatment. And finally, I would like to once again thank our Egyptian colleagues for this invitation. I wish today's online session a smooth and productive exchange, and I look forward to more opportunities for the collaborations in the future. Thank you.
好，预祝本次会议圆满成功，也预祝我的学生吧，陈雷教授能够给大家带来精彩的演讲。谢谢大家。
Thank you, everybody. I will take the microphone to share my opinion, and I am the student of Dr. Jiang, so I will start my presentation.
Thank you so much, Professor Jiang. Thank you so much for this pleasant introduction and a nice, friendly speech. We also look forward for joining the conferences and the scientific activities held in China, and we are welcoming the institutions, the Chinese professors from the Zhejiang Provincial Hospital and from Guangdong Hospital to join us in the upcoming events and meetings. Thank you so much for this introduction, and we are going to shift to Professor right now, Professor Chin.
Okay.
Are you ready?
Yeah, I'm ready. Hello, everybody. I'm so glad to be invited to this webinar. My topic is strategies and techniques for radiofrequency ablation in the treatment of lower limb vascular veins. And I'm from Zhejiang Provincial People's Hospital, the Department of Vascular Surgery. Now, we know the CVD has a high incidence rate globally, approximately 90.84% in Asia. Based on the population size, approximately 100 million people in China suffer from this disease. So it's a very large amount of people have this disease. We should pay attention to this disease. And here, this slide shows us the statistics of varicose vein surgeries performed at our hospital from 2018 to 2023. The total amount of surgery increased about 2 times over the last 6-year period. The number of minimal invasive surgery has more than tripled in the last 6 years. We have performed more than 3,500 operations in 2023. And as we know, the current treatment strategies for this disease, including many different parts, no matter the conservative treatment, but also we are also use the varicosity traditional surgery like a strip. strict the GSV. We use conservative treatment to include some intravenous active drugs, and we told the patient should wear compression stocks, and we focus on the operation. We have new methods include different EVTA, the endovenous thermal ablation. We perform the RFA and the laser ablation in our hospital, and the chemical ablation. We also use we also use the foam skeletons to treat the small varicose veins. We tried the first operation, use the MOCA to treat this kind of patient. And also venous seal, we performed the venous seal in our hospital. At present, the mainstream surgical method for minimal invasive treatment of varicose veins, I think, is the thermal ablation. In our country, we have different brands of the RFA the equipment, and here we see there are 5 different brands, and they use the similar mechanical or similar the thermal ablation. Now, why we should focus on RFA? I think there are 5 different aspects. RFA provides the constant and controlled thermal delivery. It results in less post-operative pain, minimal bruising, and faster return to daily activities. More importantly, the patient report higher satisfaction and excellent long-term results. And this is very important. These factors make it a very attractive option for both surgeons and patients. Now here is the guideline in America, and so the ideal candidate for RFA is the patient in CEAP class C2 to C6 with duplex confirmed reflex lasting more than 0.5 seconds. The great saphenous vein is usually between 4 and 15 milliliter in diameter, relatively straight and easily accessible. And proper patient selection is the foundation of procedural success. So we perform our operation focus on C2 to C4 is the main amount the hospital or the patients in our hospital. Usually it's just the GSV diameter is 4 to 15 is very suitable for this operation. Here is a duplex ultrasound in the cornerstone plane. We draw this to evaluate our hospital before the operation, and we make markers on patients' legs to make it clear. And here is the ultrasound. It allows us to ultrasound allows us to evaluate the reflex mapping the entire venous system, identify incompetent perforators, and measure vein diameter at multiple levels. Precise pre-operative making play a crucial role in reducing the complications and improving efficiency. And I think a good mapping is half of the operation. Now we show the procedural workflow. The first is the ultrasound guided puncture. The basic steps including using the ultrasound to make the clear location of the puncture site. And second, we show the insertion of the sheath and the advancement of the catheter. The third part is the precise precision near the junction. And the fourth is the injection of tumescent anesthesia. And finally, segment by segment ablation should be performed, followed by compression. Each step is performed under ultrasound guidance is recommended. Now, the preferred access point is usually just below the knees. We use ultrasound to check the location, and this helps us to reduce the risk of saphenous nerve injury. And the knee level puncture preferred is usually about 10 to 15 centimeters below the knee. And sometimes it is hard to treat in some patients with obese and edematous limbs. And a micropuncture technique should be performed under the ultrasound guidance, greatly improves the accuracy and the safety. A good start to ensure a smooth entire procedure is very important, but we should use the out of plane cannulization approach. Also, I prefer to use in plane cannulation approach. Here we use 7F sheaths, all selected sheaths or appropriate diameter depending on the catheter being used. If we use the closure fast or other or similar kind of RFA catheter, we should use the 7F sheath. For example, we use Olympus radio frequency catheter, then we should use 6F sheath. And this slide shows us the catheter positioning about the 2 centimeter distal to SFJ or SPJ. Importance of the real-time ultrasound avoid the deep system injury, and this is the entering of femoral vein through the puncture point. As we can see, the catheter is in the femoral vein. I inserted this catheter from the puncture as usual, but it comes into the deep vein. So we should pay attention. Sometimes, but it's not often, the catheter will go into the deep system directly. So we should pay attention to it, to this situation. We should not inject the tumescent fluid directly without ultrasound check. We should double check to avoid this situation. Now, in my opinion, this is the most important step of entire procedure, is tumescent anesthesia. This picture shows us the catheter is surrounded by the tumescent fluid, like an Egypt eye. Tumescent anesthesia have 3 functions. It provides analgesia, compresses the vein around the catheter, and insulates surrounding tissue from thermal injury. A complete prevenous, the prevenous fluid halo on the ultrasound is the sign of perfect tumescent the infiltration. Without a good tumescence, there is no good ablation, I think. The key point of radiofrequency closure of greater saphenous vein trunk, the first is make sure your catheter is 2 centimeters from the SFJ, and injection from the puncture site to the proximal end is recommended. This video shows us a successful tumescent fluid injection. We can see the wall of the vein was compressed to the catheter. The segmental ablation will be performed, and this is the last part of this operation. We usually 7 centimeter per cycle. The catheter will be withdrawn step by step. Prorac technique is very important because it's due to the diameter of the GSV, and this is another kind of catheter we performed in operation, and we can see the ablation was performed under the ultrasound guidance. Double treatment is very important for large segments. Here we show us the problem solving. We found the catheter cannot be put into the right place, and it is hard to make it near the SFJ. Now you can see we cannot put the catheter. Now we press the sign. In real practice, anatomy is rarely perfect. Tortuous vein, large diameters, and discontinuous segments may require multiple access point and modified strategies. Gentle external compression. Now here, this video shows us the gentle external compression may help, and additional tumescence and shorten the ablation distance may also help us to overcome these challenges. Now here, this picture shows us I used 2 sheets to overcome this problem. 2 sheets were left in place to resolve the issue of the catheter being unable to advance. And the segmental radiofrequency ablation of the main tract of GSV was performed correctly. Now here is another problem. The long shears is used to facilitate repositioning of the catheter after it has been withdrawn and cleaned during treatment. This is because the tortuous main vein may be affected after the injection of tumescent fluid. So I will use, if I use the Olympus or FKR catheter, I will sometimes I will use the launches. You can see the tip, some black was attached to the tip of the catheter. Once we withdraw the catheter, we may meet the we may cannot to put the catheter back to the position. Now here I show us the perforating veins. Here is the typical perforating vein present with venous dilation and reflux. Such kind of perforating veins may need to be treated. Here we use sclerosants to treat. Sclerotherapy for perforated veins were performed with the assistance of an assistant. More often than not, the surgeon performed the treatment independently. And we can see we also use laser to treat pathological perforating veins. Either spot laser or the circumferential laser can be used. Here is the picture we use the circumferential laser catheter. We also in our institute we also successfully performed China's first radiofrequency ablation of perforating branch vein using closure RFS.
到家来的时候，你妈是这么猛，完了你是怎么样的？然后女儿说啥？女儿说不是，但是你们跟以前不一样。
Perforating vein ablation. We use FKL catheter. Here is the ultrasound guidance. As we can see, we put the needle puncture through the perforating veins. The first step is the ultrasound examination to locate the perforating vein, then perform the puncture. And after injection tumescent fluid, the radiofrequency begins. Procedure after the radiofrequency ablation, the local changes can be seen under the ultrasound. Now you can see the needle was punctured through the
lâu rồi từ trước khi mà anh Hà đấy để học riêng ông ta hay là ai đó mà vô một cái thành bè mà nói cái chuyện gì mà sắp sắp là ông là cái Hà nên tôi cũng cho trường hợp đâu mà xong mà gọi là phải chú đâu để mà cũng chào là đọc tất cả về sẽ gọi giỏi vì tông đợi cho Hà hồi xưa là Hà đâu đọc tóc đây anh nghe chuyện đó
Dr. Lai, can you just wait for a second because we have someone opening the mic.
Chung là phó tổng của VIC và là cái chủ tịch của xong sắp trở về xong là bị đánh vừa rồi mới được cái tưởng là tháng 7 là bay luôn rồi tưởng không bay màu wow. Chung về tới tiếp dụng đúng rồi anh ví dụ cái ngắt tỉa quá vui chú sĩ ở nhà cái này nè.
Now we put we will check the location. Now we put the sheath into the perforating vein. Last slide shows us I punctured through. Now we put the sheath into it. I think sometimes it's due to the anatomy of the perforating veins and the puncture angle. we can see the tip of the sheath. It is in the vein. Now we put the catheter into the vein. Withdraw the sheath. The tumescent fluid is injected with a syringe. The fluid should be injected around the tip of the catheter. Now we can also observe local changes after the radiofrequency treatment. The last part is very important. The last but not least is the post-operative care. After the surgery, we use elastic tape. Is wrapped for 2 days, and then we changed it into compression stocks. We told the patient they should warm it for 2 to 3 weeks at least. If necessary, post-operative measures to prevent DVT were taken in our institute, like the compression therapy, or we use some drugs to anticoagulate. Here is a case. We perform the trunk radiofrequency, the pathological perforated vein closure, and we use sclerosant to treat this patient. This patient is C4, maybe in a small location of the lower leg. There is an ulcer in front of the leg. 3 weeks, 7 weeks, 3 months, 7 months, we can see it was perfect. So here is my presentation. Thank you, Dr. Mohammed, and every colleagues from Egypt. Thank you very much.
Thank you so much, Professor Lai Chen, for this very interesting presentation. Actually, I'm just wondering if you have some more preference of the thermal ablation of the perforators rather than sclerotherapy. If you actually do prefer this more than sclerotherapy or not?
More than what? Pardon?
Do you prefer thermal ablation of the perforating veins more than the sclerotherapy? You prefer the thermal ablation than sclerotherapy or not?
I prefer thermal ablation more than the traditional therapy operation.
And you prefer radiofrequency rather than laser ablation?
I prefer radiofrequency. Radiofrequency provides lower temperature in a local site. The HIT is EHIT is lower than laser, in my opinion.
Okay, very good. Now, do we have Professor Wang is Professor Wang with
if
us?
you may, Professor Muhammad, there are a few questions that came around. One of them is, will you ablate perforator with radio frequency as it has 6 centimeter ablating zone? Professor Li Chen?
Yes, I will perform it.
Okay, so how will you do that if it's like 6 centimeter from the ablating zone?
6 centimeter.
Yes.
Which part?
The question again is, how will you ablate the perforator with radio frequency as it has 6 centimeter ablating zone? I believe he's talking from the GSV.
I will use the incision to do a ligation in the local to treat first. Then I will perform the radio frequency like as usual.
Okay. There's another question which says, what about the blowouts noted less than 4 millimeter diameter?
Let me check.
I think the colleague asking about the blowout size, maybe he is trying to clarify if you attack the 4 millimeters blowouts that are relatively not that large. Are you going to attack such blowouts with thermal ablation, either radio frequency or laser, or you prefer to do the sclerotherapy, the traditional sclerotherapy?
I will not perform the radio frequency. I will perform like injection of the sclerosant, or we use local ligation of the trunk. Then the varicose veins, I will do the strip. Other parts.
About the sclerosant, we know about the etoxysclerol as the most famous sclerosant used in this regard. Do you think that there is another sclerosant that you prefer, or you have any experience with another sclerosant?
I use the sclerosant is original from Germany. I think it is very popular. I also use the brand of Chinese brand.
Okay.
There is no big gap from different sclerosant.
Maybe they are the same ingredient.
Not the same ingredient, but it has similar outcomes.
Similar outcome. Okay. Thank you so much, Professor Chen.
Thank you, Dr. Ahmad.
We can move right now. I don't know if Professor Wang is currently with us.
Professor Wang is here. I'm not sure if she can hear us.
Yes, present, dear President, dear Chair, and I'm sorry, I don't know what's the reason I can't turn on my the camera, but I can hear you and you can hear me, right?
Yes, we can.
Now can I share my screen?
Please. Yes, we can see it.
Okay. Let me set it to play. One moment.
Okay. All right. So should I begin right now?
Yes, please, Professor Wang.
Okay, dear chairman and dear the moderator, dear the audience, and today we are very happy to have the webinar meeting with our Egyptian vein experts. And I would like, after the previous speakers introduce the radio frequency in detail, I would like to update on the minimal invasive therapy on varicose veins in China. And I'm a vascular surgeon from the Department of Vascular Surgery, Guangdong Provincial People's Hospital, Guangzhou, China, which is a very beautiful city located in Canton, the southern of China. In China, varicose vein is a very popular disease. It is reported in this literature that the prevalence of varicose veins is about 8.9%, and more than 100 million people suffered from this disease in China. So I think maybe the incidence of the venous insufficiency is more higher than 8.9%. We are under investigation on the prevalence of various cause vein recently in several provinces. And so today we would like to share the superficial trunk vein treatment and the varicose veins updated in our country. Before 2000, the open operation of high ligation of great surveillance vein and stripping is the dominant surgery for the varicose vein in China. And after 2000, and laser ablation was introduced into China, but it was not that popular, and the employment of this laser ablation was not was even less than the high ligation of great surveillance vein and stripping. And after 2019, and due to Medtronic and video frequency was introduced into China, and with the permission of the Medtronic and our first team to visit the day surgery in United States, and the radio frequency, and later on microwave ablation was more and more popular. So this is the photos, like the Medtronic invited several vascular surgeons to visit the Venus Institute. Actually, it is the day ambulatory surgery, like the day surgery in United States. And this changed our conception how to treat the varicose vein in China. Usually we put the patients in the floors and for 7 days with the open surgery, and after surgery and the compression, and observe the several days, and let the patient discharged from the hospital. But ever since 2016, and our vision to treat the superficial trunk vein changed, and ambulatory day surgery is more and more popular in China, especially in Professor Jiang Jinsong's institute, and they performed lots of various cause vein in their clinics, and they set up very good examples samples for example for the day surgery in China. And in 2019, the first non-thermal, non-tumescent glue was introduced in China, but it was only in a limited area because the price. So it's only limited in Hainan province. This is a study published in 2017, and it's a national survey the operation modes for the various cause vein in China. And still in 2016, traditional surgery was still more dominant. And we can see like laser 24 and the radiofrequency even 5.6, and psychiatric therapy is 3.1%. But recently, it has greatly changed. We are under investigation how the surgery modes changed after 2016. And we have performed so lot of minimal invasive surgery, and there's a paper compared with the microwave and high ligation stripping in China. So this study compared with these two surgeries and shows that the microwave ablation was less operation time, less post-operation stay, and less complication and higher certification compared with the microwave and the open surgery. And this study compared with in China, compared with the microwave ablation and the radio frequency. And we can see like they have the similar the microwave have the pain for the patients was higher than radio frequency, and the microwave had more pigments, although there's no significant statistic significance. And for the quality life, the patient see inquiry score, like radio frequency has higher scores than the microwave. And the 1 year recurrence is equivalent. And so the conclusion is that the both ablation techniques are safe and effective, but the radio frequency is associated with relative higher treatment costs, but shorter hospitalization and a better quality of life improvement. And in our hospital, we compared with the radio frequency and open surgery, and it included 83 radio frequency and 96 with the open surgery. And there were fewer complications in the radio frequency group than in the control group, than in the open surgery. And the recurrences was of various cause vein were equivalent. And the Civic Q20 score was higher in radio frequency. So our study shows the radio frequency compared with the sclerotherapy is more advantages than the open surgery at the operation time, length of hospital stay, and the post-operative complication and the quality improvement in the radio frequency is better. And for the various cause veins, and after 2016, with the introduction of the venous hook and the phlebotomy is more and more popular in China now. And foam sclerotherapy and most for the varicose vein and less surveillance vein. And in China, we seldom use the foam sclerotherapy for the greater surveillance vein. And in this study from China, like for the the lesser surveillance vein insufficiency, ultrasound guided foam sclerotherapy is safe and effective for sympathetic the smaller vein is the lesser surveillance vein insufficiency. And for NT venous seal was first performed in Hainan in 2019, and the Medtronic will bring this venous seal next year maybe, but we have the domestic NT glue in has been testified from the clinical trial, but it hasn't been in the market yet. And in old days, we used the Travix a lot, and for the large areas with air varicose veins. And nowadays, because the phlebotomy, so it's seldom used, mainly because it's painful and it needs the anesthesia. Intubation is needed. And for the anesthesia for the varicose vein, and before 2016, the intubation usually was maybe like was frequently employed, and the epidural. But after 2016, more and more patients was operated with the local anesthesia or nerve root anesthesia, and some hospitals or some patients with the large area with varicose vein use the epidural anesthesia, and the interpretation was less and less nowadays in China. And the management conception has changed after 2016, and it is encouraged by the Ministry of Health with the ambulatory surgery, because it can shorten the hospital time and shorten the less economic burden. So nowadays, and the hospitals set up the day operation clinic, and maybe half of the patients were performed in the day surgery. We set up a management protocol for the day surgery and the floor patients. And this protocol SOP shows like with the procedures following this SOP, there will be less complication, and the patient satisfaction is higher. So in summary, and minimal invasive surgery for varicose vein was dominant now in China, but we need to update our data of the operation mode. And the glue hasn't been studied yet, and but it is very promising. It's very soon in China, and many hospitals encourage the ambulatory surgery with like 2 days with like 1 day with the time with the examination in the outpatient clinic, and operation on the surgery day, and leave at the same day. but we still concern some patients because we do not have a very good community care. So in some in still in some hospitals we have the patients in the hospital, but only 2 days. And anesthesia mode changed from the intubation to the local and nerve root and epidural anesthesia. And we need more data to be updated in this area. So this is my share of the minimal invasive therapy of the varicose vein in China. Thank you very much.
Thank you so much, Professor Wang, for this very informative lecture. We knew well that you had some commitments at work, and that's why we didn't have the privilege of letting us connect with you earlier. But it is very fine. The lecture was very clear, and we are privileged to have you with us today. And thank you so much for this very informative speech. Actually, I'm wondering, because we in the field of interventional radiology, we always think about that microwave is a bit harder than radio frequency, a bit less controllable than radio frequency. So in this area, when you do the tumescence anesthesia, are it is exactly the same risks, the same safety to use the microwave ablation compared to radio frequency, or you think that microwave could be a bit stronger or maybe uncontrolled?
Yeah, I think why they introduced the microwave ablation, I think first they used for the liver, the liver nodular. Then the factory the industry in change their they I think they like like amplify their indication and to the various cause vein. But I think that is too hot and it is difficult to control, and the patient will feel pain after the treatment. Yeah, I think radio frequency is more safer because the temperature is only 220. Well, microwave you can't control. So that's why I think the study shows the radio frequency has the better patient satisfies than the microwave. But microwave is not so popular it's not that popular in China.
Okay. And about the issue, you told us about the anesthesia. We always go for local anesthesia or maybe epidural anesthesia if the area to be covered is a bit large. However, we didn't ever do general anesthesia or intubation. Do you think that still there are some cases who need to be intubated right now in practice?
I don't think so. I think the nerve root actually is a very good choice. Um, I think even better than the epidural because in some old patients, the epidural anesthesia will cause pain after the anesthesia. I strongly support the nerve root. I think that is, if the anesthesia is very handful with skillful with this technique, and it can cover it can it can let the patient feel comfortable even with the large areas of large area with various cause vein, and there's no epidural complication. Even epidural anesthesia will be not good for the patient with the aspirin or anticoagulate.
Yes.
And Asian people usually suffered more hematoma than the Western people. So epidural is not very safe. So
Yes. Okay. So the nerve root approach is done through the femoral nerve? No?
Yeah, from the two sides. So one is the ground, and the other is around the knee.
Okay. Very good. Very good. Thank you so much. There is a question from the platform. I read the question and currently I can't see it. Maybe.
I have typed the answer.
Yes, very good. Very good, Dr. Chen. Thank you so much. Okay, great. Now, Dr. Chen is going to give us a video presentation on the surgical and interventional approach. If you can just start, please, Professor Chen.
Okay. I will share the video. Can you see it?
Yes,
5F vascular sheath is used during.
Can you see the video?
Yes, sure.
Do you hear about the sound?
The procedure.
Okay, I will start.
5F vascular sheath is used during the procedure. Head up, foot down position, with ultrasound guided scanning along the course of the great saphenous vein. Focal varix-like venous dilation. Mickey Mouse sign at the saphenous femoral junction. Under ultrasound guidance, puncture is performed at a relatively straight segment of the great saphenous vein trunk. The puncture site is usually located below the knee joint, but not lower than the middle upper third of the calf. Insert a 5F vascular sheath. Curaway Endovenous RVA catheter, 1.6 mm diameter. Measure and locate the catheter insertion length in vitro. Gently insert the radio frequency catheter. Push the catheter under ultrasound guidance. Use hands to gently pull the catheter through smoothly. After the radio frequency catheter is placed, the patient takes a head down, foot up position or a supine position. Locate and measure the catheter tip, positioning it approximately 2 centimeters from the saphenofemoral junction. Under ultrasound guidance, follow the course of the great saphenous vein. Inject tumescent anesthesia into the interfascial space between the deep and superficial fascia. Empty the blood to allow the vein wall to closely adhere to the catheter, prevent thermal injury to surrounding tissues, and reduce pain. It is recommended to inject tumescent anesthesia under ultrasound guidance along the skin overlying the catheter, approximately every 10 centimeters, with 10 milliliters per 1 centimeter segment. Under ultrasound, confirm the vein is 1 cm from the skin after tumescent anesthesia injection. Inject sufficient tumescent anesthesia at the saphenofemoral junction and fully evacuate the blood. After sufficient tumescent anesthesia injection, the catheter tip temperature drops from around 37 C to approximately 25 C. After tumescent anesthesia injection, ultrasound shows a concentric circle sign, and the treated vein trunk is 1 cm from the skin. Reconfirm the catheter tip position and start the radio frequency treatment. Rapidly heat up and steadily maintain at 120 C. Each treatment circle lasts 20 seconds. Perform 2 radio frequency treatments at the saphenofemoral junction. Observe the ablation effect under ultrasound. Withdraw the catheter according to the scale markings. Perform segmental ablation, ensuring continuous, uninterrupted treatment. Perform an additional radio frequency treatment at the site of focal varix like venous dilation. Withdraw the catheter. When continuous marker points appear, it indicates that the sheath should be removed after this ablation. Withdraw the vascular sheath according to the marker points. Before ablating the final segment of the GSV, the sheath must be fully removed, then start the radio frequency treatment. When the catheter's triple marker points appear, perform the final radio frequency ablation. After the final ablation, remove the radio frequency catheter. Perform a complete ultrasound examination. Sclerotherapy injection treatment. Prepare foam sclerosant using the Tessari method at a 1:4 ratio. Inject foam sclerosant precisely under ultrasound guidance. Use ultrasound to confirm that the foam sclerosant has fully dispersed. Branch vein, performed with point-by-point stripping. End of surgery, 5F vascular sheath, 1.6 millimeter catheter diameter, minimal trauma, mild pain, and good patency. Apply compression bandage along the course of the GSV. Securely fix the compression bandage. After the procedure, safely transfer the patient back to the ward.
Okay, here is the end of the video.
Thank you so much, Professor Chen. It was a very nice and clear video about the procedure and the product line. Thank you so much. I'm just asking if there is a question. It's not here in the question and answer box. All is okay. Okay. Maybe it came to the end of our webinar today, and I'm truly.
Yeah. Sorry to disrupt. I have a comment to answer the. How will you ablate the perforators with RFA as it has 6 centimeter? I have comments more comments. In this case, I will use a short segment radiofrequency catheter. The video shows us Dr. Jiang has used the Curaway radio ablation catheter. The catheter tip is 7 centimeter. Our hospital, we only have the 7 centimeter catheter in our hospital due to the government insurance policy. We do not have other the length of the catheter, but the Curaway have centimeter, 7 centimeter, 5 centimeters, 3 centimeter, 2 centimeter, and 1 centimeter catheter tip for the global market. Maybe you can have this kind of catheter, and the diameter is 1.7 or 1.6 or 2.0, 2.3 millimeter diameter of the catheter. So you can use you can choose more kind of the catheter to do the perforator vein treatment. So
yes, that's very clear. Very good. Actually, I'm wondering about the last step that we saw in the video. The last step, there was branch vein ligation, and I don't understand how this is going to impact the outcome. Despite we used sclerotherapy foam and we performed the ablation. So, is it important to do this branch vein ligation?
I think so. We should perform the ligation, especially the varicose vein. The diameter of the varicose vein is very large. These patients, we will do the ligation. Now you can see the patient is lying on the bed. Once he stands up, the varicose vein will be seen clearly. Such patients, I will do the ligation. But the ligation incision site is small, and after the heal, it has less pain.
Okay, quite clear. Thank you so much. Thank you, Professor Jiang and Professor Wang from the panelists, our distinguished professors. Also, Dr. Chen was, his speech was very informative and clear. Thank you so much, everyone, and I'm looking forward for your attendance in the upcoming STEER events, either through webinars or through the conference that will be held on May in 2026, our first STEER conference. And as Dr. Omar said, we are looking forward for a visit to the Egyptian Grand Museum. We think that this will be a very good opportunity to show you the Egyptian civilization. Thank you so much for your contribution, and thank you for CureAway and Synergy. Thank you so much.
Thank you. And we are welcome you to China and to visit our Great Wall and our lovely panda. And
yes, sure.
Yes,
we will be happy to come. Yes.
Yes, we will enhance the communication between two countries, and both of the countries are very ancient civilization countries.
Yes,
so
sure,
we have
sure.
a lot of common sense.
Yes, sure. Thank you so much, Professor Wang, and thanks to the panelists. And have a good day. Thank you so much.
Have a nice weekend. Thank you.
Thank you.
And Dr.
Bye-bye.
Thank you. Thank you so much. Bye.
Bye.